Hello and welcome to Why Medics Matter, a podcast by doctors for doctors in association with Doctors Training. We are your hosts. I'm Dr Amy Burbridge.
And I'm Dr Simon Fraser.
And today we have a really exciting episode coming to you. We are joined by Dr Mike Blaber. He is a palliative care specialist working in Birmingham and is also the wellbeing lead for resident doctors. Thank you so much for joining us, Mike.
It's a pleasure to be here. Thanks for having me on.
So the reason you're here today is to talk about an emotion that we don't talk about enough in medicine and probably in life, actually. And that's shame. And I think we should just start with, how would you define shame?
It's a good question, isn't it? Because I think it's a concept that is more familiar in some cultures than it is in others, and maybe it's less familiar in a Western culture. But essentially, shame is the sense of needing to hide oneself, of not being able to be seen as you fully are. So there might be aspects of a person that you want to not disclose, to not be seen, because you feel that it is somehow unpresentable, or that to be seen in that particular way may have a negative consequence, either for yourself or within the community that you're part of. And I think it is a phenomenon that is seen within healthcare in a number of different ways. But that's probably how I define it. But that's, it might not be a dictionary definition, but that's certainly my understanding of the concept.
And do you think that as health professionals, it's something that we are aware of enough?
I think probably not, actually. I mean, I think there is a sense in which as one goes through training and then becomes a more experienced doctor, you can put on layers of professionalism that after a while begin to become synonymous with your identity, so that I am a doctor, that's who I am, rather than, I'm a father of 3 daughters, owner of a puppy, Arsenal fan, occasional baker, that kind of thing, who also happens to be a doctor. And it's not that being a doctor is, I wouldn't say that's just something that I do, because I've heard that before. And I think there is something about the profession which causes us to embrace a vocation of service and of wanting to become the best version of ourselves that we can be in playing our part within medicine. So it does become part of our identity, but not the sum of it. And when it becomes the sum of it, I think that's where things can become difficult. And particularly if something doesn't go so well, it can really threaten your sense of self, and therefore your sense of security and of presentability. And that's where shame can come in.
Absolutely. And it's certainly something that I wasn't really aware of, even as an emotion, or I could put a label on it until probably 5-10 years as a doctor, because you're not taught about it.
No, you're not. And I think, therefore, it can compound that sense of something needs to be hidden, because there aren't really the words given to be able to express that feeling. And if we're not careful, therefore, it can be my dirty little secret. I've got this feeling, and it's an uncomfortable feeling. And no one else has that feeling, because everyone else seems to be getting on just fine. And so in that sense, it can be quite closely related to what we might know of as imposter phenomenon. The sense of everyone else is doing okay, but I'm not feeling okay. And that can get consolidated when it's not spoken about. And so if we haven't got the words to put to the emotion, then I think the power of becoming more isolated within it kind of ramps up. And that's where I see people often running into some difficulty.
And when you say people are running into difficulty, what sort of things are happening?
Yeah, so I think it's probably there's different manifestations of this I see quite frequently in my role as a well-being lead. Actually, also in palliative medicine in different ways as people are adjusting to changes. And I've certainly known it in my own life as well, and in my own professional life. I think the kind of difficulties that it can cause is a loss of confidence, and there are different ways in which people will respond to that. So sometimes that will be, overworking in order to try and, be okay. It can lead to kind of perfectionism. It can lead to a kind of anxiety spectrum thing of needing to check everything and double check everything and triple check everything. And certainly that was how it played out for me in my own experience of it. And other times it can lead to isolating from others, so becoming a bit of a lone ranger because of the fear of being found out if you're kind of too integrated. So I think there's a number of different ways that it can play itself out, but oftentimes it looks like loss of confidence, and I think that's how that initial way in which it's presented when I'm asked to spend some time with someone is that sense of I just lost all confidence. And underneath it all is the belief that I shouldn't be feeling the way I'm feeling. I shouldn't be having uncertainty when it comes to clinical decision making. I shouldn't be having, anxiety around a novel experience that I've had. And oftentimes one of the most therapeutic things is for people to hear, most of us go through this. Most of us experience this at some point. And in fact, the evidence is that the prevalence amongst healthcare professionals is really quite high. Not all the time. We're not all perpetually feeling it, but at some point in our career, most of us do experience something around imposter phenomenon, something around an unease with owning the position we find ourselves in, which can present a challenge. And I think being able to talk about that openly is a important aspect of moving through that challenge rather than being overwhelmed by it.
Do you mind if I come in, maybe? It was interesting talking about imposter phenomenon leading to maybe the feeling that I can't admit I'm struggling, or I find things hard, which might lead to an emotion of shame.
Yes, yeah, indeed.
And then shame. Can you get into a downward vicious cycle of that shame imposter phenomenon? Is that something?
Certainly, yeah, I think so. That sense of I'm not enough, I should be more. And in trying to be more, I feel even more anxious, and therefore, I can't even, get myself out of it. And so it can be certainly, I think, reinforcing. I think from the point of view of resident doctors and training doctors, there's the additional element of the threat that if I speak openly about this, it might have some consequence to my progression. And that also can lead to a kind of sense of I'm on my own here. No one's got my back. In fact, one of the difficulties with just healthcare in general, I think, as a culture and particularly in training, is this belief sometimes that people have not got my back. Actually, more often than not, that's not the case. Actually, the very vast majority of the time, everyone wants other people to succeed and are willing to play various parts to enable that. And there is help available, and there is, support out there, and the recognition that training doesn't happen the same way for everyone. It can look different, and can take a more bespoke kind of manifestation. But still, the belief underlying it is, I'm not sure that anyone's got my back, and there's a lot of stick. There's not a lot of carrot, and I'm a bit worried about disclosing any kind of weakness.
Absolutely. For me, shame almost feels like this is going to sound random, like a slow growing fungus that starts quite small, and it may be something that's happened at work that you think, I did a bad thing. That was not the right thing to do. And then you get this little nugget of something that starts, and then you then start to go, well, I am bad then. I am a bad person. I did a bad thing. I did an immoral thing. And then it just builds and builds and builds and builds. And for me, I was trying to imagine what shame was for me. And it was like I had a rucksack on my back with shame. And that rucksack got heavier and heavier and heavier. And as the rucksack got heavier, I got shorter and shorter and shorter. And at work, I became more hidden and like insular. And, you know, occasionally that rucksack's still there, but sometimes it's a light rucksack. Sometimes it's like a mini rucksack. I don't know. It was just trying to figure out, and I know it affects us all differently, but I don't know. Does that resonate?
Yeah.
Or does it just sound crazy?
No, it doesn't sound crazy at all. Brené Brown's done quite a lot of work in shame. So she's obviously an expert at it, written both academic and popular works. And so she distinguishes shame from guilt. And she says that guilt sounds like I made a mistake. And very often, you know, a mistake or an unwanted outcome is a catalyst for these kind of feelings. You know, something goes wrong in the workplace, or there's an outcome that no one would have wanted. Guilt sounds like I made a mistake. Shame sounds like I am a mistake. And so you so personalize the experience that it comes down to my own contribution to it, and the world almost contracts into the part that I've played and the role that I've had in this situation, so that rather than feeling like, well, sometimes these things can happen and no one would choose it, and we want to learn from it so we can extract, you know, what we can and move on and try and prevent things from happening that way again. But when it becomes turned inwards, then all of a sudden the whole world is a threat, because it's really undermining my sense of self, and that bag becomes heavier and heavier and heavier. And I think what that can do, you know, if it's not then given the opportunity to be brought into the light, so to speak, and to share the load, you know, and that's, you know, I suppose quite a fitting phrase, because it feels like a heavy load to be carrying. Then without that, one's capacity to make decisions moving forward, or to try something new, becomes diminished, because everything's so threatening. I don't want to put myself in a position where I might be exposed again. So having safe spaces where you can talk about these things without judgment. Again, Brené Brown says that if you were to put shame in a petri dish, the perfect conditions within which it would grow would be silence and judgment, you know. And so, therefore, one of the antidotes to that is being able to have safe spaces where you can talk about it, where you can actually own, this is what's happened and this is how it's made me feel. And I've been in a number of different circumstances where there's been a setting where that has happened, and oftentimes quite senior people then sharing their own stories of things that they've been through, how it impacted them. And almost like you can see the shame dropping off people as they realize, oh, it's not just me. Oh, actually, we all go through this kind of thing. Oh, and we're in it together. Oh, great. And that's, you know, that sense of togetherness is just so vital to medicine, isn't it? It's the absolute heartbeat of healthcare, is that you're not in it on your own. We're in this together. Healthcare is a team experience. And to the extent that you feel that you're part of something bigger than yourself, you know, it's a lighter load to carry, and you become better known and understood, and, you know, therefore it feels safer.
Mike, how do we create those safe spaces? So for people out there who are colleagues, who are supervising, who are mentors, how do we, given the fast pace and the transient nature of teams, how do we do that better?
Yeah. I mean, I think it will depend upon the culture of each team. So within our palliative care team, we have a really good culture, and we call it a senior leadership team. And it consists of doctors and nurses and therapists who we'll meet weekly and we'll have a huddle and we'll check in. And part of that is an opportunity just to say, how are we all doing? Is there anything we're struggling with? And it normalizes the idea that there might be. And because there might be, there's an opportunity now for us to talk about that so that we can own it together. Because really the follow that is there anything you need help with, anything we can help you with? And it's not just about sharing the things you might be struggling with, it's also sharing our successes. I mean, sometimes we can feel a bit embarrassed to say about the things that go well, for fear of being misunderstood too. And all of it is this sense of, whether it's a negative thing that we want to hide away or a positive thing we want to hide away, it's the sense that it might have an impact on our sense of self or how we're perceived that we might feel uncomfortable about. So being able to be fully known, I mean, as human beings, we just need to be known, and to know connection. So having those kind of huddle meetings within our team is helpful. Within the resident doctor cohort at the trust I work for, I do something called samosa and support every fortnight, so we give samosas. And here in Birmingham, we've got the best samosas in the country, to be fair. We give some samosas. We have an opportunity to talk about the good, the bad, and the ugly of being in healthcare, and some of the successes from the last couple of weeks, and maybe some of the challenges. And oftentimes, what happens is, I might be there, and some other colleagues might be there to facilitate the discussions, but really we're bearing witness to the resident doctors supporting one another, because invariably whatever story is shared, someone else in the room can relate to that and can share some insights into how they moved through that experience. And again, you can just see the therapeutic effect of knowing, great, I'm not on my own.
How do you, if you wanted to really mess somebody up, how does a supervisor or a colleague induce shame emotions?
Yeah, good question. Inverse.
Not advising anybody does it. That's a really bad thing.
Yeah.
But I think inadvertently we do it.
Yeah.
What's the trap?
Yeah, I think that's a good question. I mean, I think it's the overlooking of a person's humanity. So, and sometimes that can be by just being misunderstood. So even comments like, well, in my day, we did X, Y, Z, it might be true that, there was a time where hours were longer or things like that, but it might not be helpful right now to be sharing that.
Yeah. And
it probably misses the point that the experience is quite unique to this person. I think as much as possible, if one is sharing to a colleague and then they express either shock or they, or disinterest, I mean, either or, then that can be unhelpful, because that can reinforce that sense of, oh no, this is something I shouldn't be sharing. I need to hide away. And also, I think the suggestion that from an educational supervisor point of view, that this immediately has to immediately zone in on the implications this might have on your forward career, and that can be for good or for bad. That can, if it just immediately gets reduced to what this means for progression or for your portfolio or for your, then that can just again reinforce a sense of there's a bigger thing at play here, which is somehow threatening to me. So I think those would be things. I mean, it's a really good question, Simon. I never really thought about it quite like that before. Have you got any thoughts?
I don't know. Maybe you've been listening. I don't know what your thoughts. I think we can. I think sometimes I was also thinking about culture. and backgrounds and
Yes.
a lot people having to adhere to a norm and not feeling belonging, and I suppose the blame culture. When we feel humiliated or when we raise concerns or ask questions, and that can make us feel stupid and ashamed. I don't know what you think, Amy.
Couple of thoughts. I think as the NHS and the pressure that we're under at the moment, it has a capacity. I know it's not like an entity, the NHS, but to dehumanise us. And sometimes I go to work and I feel like I have to fit into a mould of what a consultant should be like in acute medicine. And I am not in any mould. And if I'm not working how I should, then, or how people tell me I should, then I'm not allowed to be me. And the shame that follows that, even yesterday, if something happened and I was like, oh God, I'm awful, da, 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 da. And it was nothing, but I think we're under so much pressure that we are no longer allowed to be authentic. And the best piece of advice somebody ever gave to me was at a consultant I worked with at City Hospital in Birmingham. And I said to her, what would you tell me to do as a consultant? And she said, be you, be authentic. Because for the previous, probably for 10 years, I was acting as a consultant. I felt like I was being on stage every day. Like, this is how a doctor should act. And actually, when I became more authentic, wearing what I want to wear, taking a long time at work doing things. I like to say thorough rather than slow, but, and I feel like there is less shame when I'm allowed to practice in the way I want to practice. However, as consultants, when we are with resident doctors, I think we can probably induce shame by not allowing them to practice how they want to practice and say, well, this is how you need to do it, like me. And I think we need to let people find their way a little bit more. And everybody has their own style. Everybody has their own personality. There's no one right way. And I think we need to allow people to be themselves and find their path a lot more than we do.
Yeah. I mean, very often so I on average meet somewhere around kind of 3 resident doctors a week, from a kind of pastoral support point of view. So in my wellbeing lead role, I'll have some upstream projects which are about trying to make things better for everyone, and then some downstream intervention where there are people who are going through particular difficulties and struggles. And one of the first things that they need to hear is, you're not the only one who's been through this kind of thing. Okay. And I'm not saying that I know exactly what you're going through or how it feels, but I want you to know that I weekly meet people who have got a similar kind of experience right now. And also, I want you to know there are lots of options that are available to you. And for some, they need to know that the option of not staying in medicine is there. In fact, that can be very therapeutic. I don't know anyone who's actually at this moment in time taken that option to. Actually, I do know. So, well, my wife is one who's no longer practicing, but as in recent years, there's no one who has taken that option necessarily. But knowing that, I don't have to do something if it's really doing me harm, is really helpful. Equally, knowing that there are others who have been in this situation when they felt like that was the only solution, to who some time on are actually finding they're enjoying the fact that they're able to play their part in healthcare as a doctor. So getting rid of the sense of being trapped, and I guess that's what shame does. It traps us in a feeling of claustrophobia, and there's no way to be myself. The mold, I don't fit the mold here. And say, well, no, there are many ways in which we can shift that mold so that it's a good fit for you. But you just need to know that there are all these options on the table. And so that you could breathe out in that sense. And it's also just helpful for them to, and I'm going to go on this journey with you. Yeah, because you just might need some companions to help you to work through your thoughts, because sometimes they can be confusing for any of us to just be left with our own thoughts.
Just picking up on what you said about foundation doctors, other doctors leaving. When I was Director of Medical Education, I had probably at least 3 foundation doctors leave. 2 by choice, 1 probably indirectly managed the system, so they were forced to leave. If we think about it, a lot of people choose to be a doctor when they're about 12, 13. They have this weight of expectation through A-levels, through university, getting through, coming to foundation. And I think a lot of shame comes from family expectations. People recognize that, you know what? I've trained as a doctor, I've got the degree, but actually this isn't what I want to do. But actually, how do I tell my family? They're so proud that I'm a doctor, particularly from different cultural backgrounds where the status is high. But I've seen 2 doctors really take a positive step, use a degree to do something different. And I used to think, oh my God, it's a failure of our foundation system if somebody leaves. And I think we think that with doctors, and sometimes we project our own values.
I agree. I mean, my wife is flourishing outside of medicine in finance, and she's loving that. And she's applied lots of the skills that she learnt in studying medicine to that particular arena, and she could have stayed in, and that would have been okay too. But she decided positively not to. And I think recognizing that there's a degree of agency here, you can make a choice, you're not trapped. And, but I think it's just quite important to bring someone to that, to try to support someone to be brought to that point, so that if a decision is made one way or another, they do see it as a positive decision that I am making, not something I'm being forced into one way or another. If at all possible, to achieve that.
I think I want to sort of summarize where I am in a moment, but I just want to sort of acknowledge that the fact what your trust has done, as you said, you've got your upstream projects and you've got your downstream intervention support by somebody who's a specialist in discussing emotions. To come from your palliative. Something people listen. We talk about what is a good wellbeing intervention, and I think wellbeing interventions get a bad name because it feels like I'll put some yoga on. I applaud what you're doing, and I think it links to getting coaching and different levels of support, what I can do as a supervisor. But when maybe somebody needs some extra input and support, if I just reflect on what I've heard, is that okay? You said shame, in a simple definition, is hiding one's true self. Because of the fear of negative consequences or judgment. So don't worry, your lights popping off the background will make a good cutout. Let's leave this in. And we put on this mask or this layers of professionalism. And the risk is, and there's a bit what you say, Amy, you had this, and if that becomes you and your professional identity, that makes us vulnerable. When we hide our true self, it can lead to loss of confidence, and we try and compensate by overwork and perfectionism. And I love you do as imposter phenomenon, not syndrome, because they are sometimes they're natural but not helpful, and it's anxiety. Given the wealth of wisdom you've got now and what we've talked about, and your other life experiences, if you were to go back to see Mike, age 23, hitting the walls for the first time, what bit of wisdom or advice would you give yourself?
Yeah, good question. I think one of the things I might say is that that this doctor and training experience is not a tightrope that you are always in danger of falling off. That it's a much wider road than you believe it to be, and that many of the consultants and senior clinicians that you look up to as a 23-year-old starting out have been through more challenging times than you would believe. and things have not been a linear line of successes, but nearly everyone will have their story of times when they've felt either overwhelmed or insecure about their particular role at a particular moment in time. And so that would have been helpful to know, because then the fear of being found out as less than what people want me to be or what I ought to be would just be diminished by the reality that people have more realistic expectations than you think, because they know themselves and they know their own journey, therefore, in experiencing what I'm currently experiencing as a 23-year-old going through the system. So I think that would be one of the things I'd want to say.
Thank you so much. That was really enlightening. So many takeaway points, but I think from what you've said as well, I really like the idea of, well, number one, the samosas and support is great. But also it's about connection and compassionate connection and trying to build that compassionate community at work. And that community can have 2 people or 3 people in it, and that's okay. It doesn't need to be a big intervention. We can do that within our own teams, and even within a team, that's okay.
Yeah. I remember reading during COVID that the 2 things that were highlighted as most important to help people to get through it was strong leadership and a sense of connection, togetherness. And I think that's true of just life in general, and of certainly experience in healthcare. Feeling like your leaders know you, they want the best for you, and so their decisions are made with that in mind, and that you are part of something bigger than yourself. And that is so important. And again, for our rotational doctors, it's really key, because it's pretty exhausting every 4 months having to reestablish your reputation and become known again, and learn a new system. Whereas if you and so we need to work especially hard to help a sense of belonging and a sense of connection, and of feeling home in a trust. So yeah,
absolutely. Thank you so much, Mike, and thank you to all of our listeners out there. Please rate, review, subscribe to the podcast, and we will be back soon. Thanks for listening. Goodbye.
Goodbye.